All right, again, my name is Dr. Aaron Frey. I'm a medical toxicology fellow and emergency medicine physician here at the University of Virginia, associated with the Blue Ridge Poison Center. And this lecture is a continuation of my radiation and radiation emergencies presentation. In this section, we are going to be dealing with the biological effects of radiation, their treatment, as well as looking at some case studies. And again, as a disclaimer, this is only for informational and educational purposes. It is not intended to diagnose or treat any medical condition. While the material has been reviewed by subject matter experts, you should always follow your local protocols and have discussion with your subject matter experts and local poison control center. And again, our objectives, like in the previous lecture, are going to be able to define radiation, understand the difference between non-ionizing and ionizing radiation, be able to give examples of the different types of ionizing radiation and have a basic understanding of them, understand the concept of low energy transfer, or LET, understand ALARA principles, understand acute radiation syndrome, and describe the medical treatment for acute radiation syndrome. So acute radiation syndrome, it is a broad term used to describe a range of signs and symptoms that reflect severe damage to specific organ systems and that can lead to death within hours or up to several months after exposure. It is caused by an external exposure to radiation doses greater than 1 gray. It typically follows a pattern of prodromal signs and symptoms, a latent period, sometimes otherwise known as an incubation phase, a period of manifest illness, or sometimes called the onset phase, and then also a period of either recovery or death, otherwise known as the convalescent phase. Now, the prodromal signs and symptoms of radiation sickness or syndrome can be things such as anorexia, nausea and vomiting, diarrhea, and mild fever. Some patients may not even know that they have been exposed to radiation and may attribute this to a viral infection. It can be very nonspecific. The latent phase, or the incubation phase, is a decrease or resolution of symptoms. It can last anywhere from hours to weeks. If a person has been exposed to a large dose of radiation, they may not experience a latent phase and may go directly to the manifest or the onset phase of radiation syndrome. The manifest illness is when signs and symptoms of damage to a particular cell type or organ will fully exhibit the disease. So the severity of this is proportional to the dose received. So the higher the dose that you have, both the faster onset of the syndrome will become apparent, and also the more severe the effects will be. Now, one key aspect to remember when it comes to the onset phase or the manifest illness phase is that the persistence of emesis and diarrhea, along with fever, are poor prognosticators and are indicators of a severe exposure. So the faster that you experience nausea and vomiting, and the more severe you experience the nausea and vomiting and diarrhea, the higher the likelihood is that you've experienced a very severe, large dose of radiation. Now, the last phase, like I said, is either recovery or death. The median lethal dose that can be expected to result in fatalities in 50% of an untreated population within 60 days is approximately 4 gray, or 400 rad. Whole body doses greater than 10 gray, or 1000 rad, are almost universally fatal. Now, the pathophysiologic process of this occurring is due to radiation damaging cells, and depending on the amount of radiation you're exposed to will determine what body organ is affected. You can have your hematopoietic system affected, and that usually happens first because they are the most radiosensitive. So it doesn't take that much radiation to start causing effects in the blood cell. You can also have gastrointestinal effects, such as nausea, vomiting, and diarrhea. You can have neurovascular effects with different types of neurologic signs and symptoms. And then you can have cutaneous effects with different types of injuries to the skin and underlying tissues. So let's first talk about the hematopoietic system and this syndrome that's called the hematopoietic syndrome in terms of acute radiation syndrome. Now, this is seen at doses greater than 1 gray. So usually about 2 grays or higher is when you start seeing this syndrome develop. When you have exposure greater than 2 gray, you get damage to the bone marrow. And obviously, the larger the amount of radiation exposure, meaning the more grays that you've been exposed to, the more severe and the faster onset of these symptoms. Now, each type of blood cell has its own relative amount of radiosensitivity. Lymphocytes are the most radiosensitive, so they start to decrease in the first 12 to 48 hours after a radiation exposure. And again, the higher the dose, the faster and the more severe the drop in white blood cell count, particularly the lymphocytes. And again, this can be used to estimate the amount of dose that has been received. Now, as your white blood cell count begins to drop, you have increased risk for infection and bleeding. So you can get symptoms of infection and complications thereof. So when you have a patient that experiences this type of syndrome, they oftentimes will look like those patients that come in that are currently under radiation therapy for cancers or that are getting chemotherapeutics for their cancer and that come in with infections. So it looks a lot like a neutropenic fever in a cancer patient. Also with this, you can start getting damage to the red blood cells. Now, the red blood cells themselves don't really get damaged from the radiation, but the bone marrow will be getting damage from the radiation. And so as the red blood cells begin to die during their natural life cycle, your body is not able to replete them. And so you get different severity of anemia. And the same thing with platelets. As the platelets start to die during their normal life cycle, your bone marrow is not able to replete those platelets as effectively. And so you have a situation where your body is not able to be able to adequately develop those cells needed for clotting. And so you have an increased risk for bleeding with this. This table here helps visually illustrate this. The bottom graph is what I really want you to focus on right now. Now you can see that on that horizontal line is dealing with time. And then on the vertical axis, you have pretty much the concentration of the different blood cell lines, such as thrombocytes or platelets, hemoglobin, neutrophils, and lymphocytes. And if you look at the orange line, which is the lymphocyte count, you can see that it drops very quickly and earlier than any of the other cell lines because those cells are more radiosensitive. The neutrophils, which are represented by that green line, they initially have a small spike, and that's just because of the acute phase reactant of the radiation exposure. But then those start to quickly drop as well. Now, if you look at the hemoglobin, which is represented by the red line, and the thrombocytes or the platelets, which is represented by that bluish colored line, they don't really drop until much later in the radiation exposure. And again, this is because those cells are not very radiosensitive. The cells start to die according to the normal life cycle. But again, like I mentioned, the bone marrow is highly sensitive to radiation. And because of that, your body does not have the adequate ability to replace them. And so that's why you see a quick drop in the thrombocytes, and then the hemoglobin slowly starts to decrease as well. Now, the gastrointestinal syndrome of radiation syndrome is what we'll be discussing next. And this is usually seen at whole body doses greater than 5 to 6 gray. Now remember, the most sensitive cell in the GI system are the stem cells, which are in the crypts of Lieberkühn between the small intestine villi. They are the precursor of enterocytes and goblet cells, and they proliferate and mature in 3 to 5 days, and then they will slough off during their life cycle. Now, when you experience a higher radiation dose at 5 or 6 grays or higher, the greater destruction and damage to the villi will occur, so that these tissues will become totally disorganized, and thus disrupting the absorptive ability of the small intestine, which is afforded to them by the crypts and the villi. So you have a decreased surface area for absorption. And the amount of surface area that is available for absorption of nutrients and fluids and whatnot is not as good. It's not working as well. And so you have decreased absorption. Now, damage to the epithelial lining and a primary defect in the GI subsyndrome will allow translocation of bacteria with resultant infections. So as these cells are damaged, it doesn't create as good of a barrier for a bacteria that's in with your gut. So that bacteria in your gut will be able to pass through that initial layer of cells and get into your bloodstream, increasing your risk for infection. And again, this is something that is very detrimental because at this dose of radiation of 5 or 6 gray, we already have the hematopoietic syndrome affecting the body, and they are having a decreased amount of lymphocytes. So they're already susceptible to infection. And now at this dose of 5 or 6 gray, we're having a dose that allows for bacteria to directly cross from the gut into the bloodstream. Now, as the cells are starting to die and are becoming disorganized, you can get abdominal pain, nausea, vomiting. You can get hematemesis. You get malabsorption and dehydration. You can have hematochezia. You can experience different types of fluid and electrolyte shifts, and all that can eventually manifest as cardiovascular collapse. And like I mentioned earlier, the sooner that one experiences nausea and vomiting, the greater the dose received. Because like we mentioned a second ago, the GI syndrome occurs at doses of 5 to 6 gray or so. So the earlier that you get these symptoms, that means that the likelihood of you getting a large dose of radiation is higher. And these are just some pictures of the intestines and the GI tract that were taken from mini pigs that were irradiated with 4 gray, 7 gray, and 12 gray of radiation. And you can see horizontally starting with specimens A through C, and then D through F, and then G through I, that as one experiences higher doses of radiation, you can see the more severe effects in those tissue samples. So now let's talk about the neurovascular syndrome. Now this occurs usually at doses greater than 10 gray. And when these symptoms occur, it's almost universally fatal. Now, you can get symptoms such as headache, nausea and vomiting, lethargy, irritability, ataxia, seizures, and it can develop very quickly at high doses. So if someone gets an exposure of, say, 15 gray of radiation, they may start seeing this pretty much at the same time as they're experiencing the severe nausea and vomiting from the GI syndrome, as well as seeing the decreased lymphocyte count that's in hematopoietic syndrome. Now, it's important to know that if you have somebody that is experiencing these symptoms like altered mental status and whatnot, if you know for sure that the dose they received is less than 10 gray, it's important that you look for other potential causes for their neurologic symptoms, because they may have gotten hit in the head or they may have fallen to the ground if the source of radiation or source of exposure was something, say, like a dirty bomb. And that can cause, bleeding in the head or other injuries that may be contributing or causing their acute mental status or neurologic deficits. But again, if the symptoms that they experience occur and it's known that the dose of radiation received is greater than 10 gray, then you have to be thinking this may be contributed to the radiation. Now let's talk about the cutaneous radiation syndrome and local radiation injury. Now, with this syndrome is discussing or describing the findings that you have on the skin, so the different types of burns and dermatologic injuries. And when these patients get exposed to radiation, initially they may only have some erythema, some pruritus, some paresthesia of the skin. It may not look that bad, and they may not think much of it. However, over the next few days or weeks, you're going to be seeing the wounds get worse. You can get suppression of sweating and diminished sebaceous gland secretion. You may start seeing edema, pruritus, blister formation, and pain. You can see changes in pigmentation, and you may also see tissue necrosis. And you can get delayed effects that can occur months to years after an injury. And you also can get things like telangiectasia, atrophy, fibrosis. And this explains why a lot of people who have been exposed to radiation or get radiation for cancer treatments oftentimes do poor in terms of wound healing if they've had any surgeries on those areas that have been exposed to radiation. Now, these are pictures taken from an individual who was involved in an X-ray diffraction accident. And you can see that on the top left-hand side is what the fingers look like at day 9. But then as they progress from day 11 to 16 to 24 to 30 and to 98, you can see that there are significant changes both in the superficial layers of the skin and the deep tissues as well. And again, this illustrates the fact that these cutaneous injuries may not look severe initially, but they can rapidly progress or sometimes even slowly progress over several weeks. And as the tissue gets destroyed or changes, again, that's a source for possible infection, and people can develop systemic symptoms and potentially have lethal consequences. So how do we treat acute radiation syndrome? Like any type of hazardous material incident or any type of incident involving contamination, we need to decon them first. We have to decontaminate them. Now, what's interesting is that radiologically contaminated patients generally do not pose a danger to healthcare personnel. Most of the patients that you'll be encountering have just been simply irradiated, and they're not really contaminated. However, because of that, we want to make sure that you use appropriate PPE, and that involves using universal precautions. And like any patient that's being decontaminated, it's usually going to be involving the use of water or other liquids to decon them. So you want to make sure that you wear appropriate splash protection, including gowns, eye protection, surgical masks, gloves, as you can see in this picture here to the right of the screen. Now, you want to have that patient disrobe, or you want to disrobe them. You want to be careful with this because if they do have radioactive material on them, you don't want to be spreading that around. So have them remove their clothes or gently remove their clothes. And then you want to put that in a double bag. If you're able to, before you actually start deconning them, it'd be great if you can get samples from their nose and mouth, so that way that can be sent to the lab to help determine what type of radiation these patients may have been exposed to. And for decon, simply just going to be using soap and water. It's important to remember to irrigate the eyes and also to not vigorously scrub these patients. When you scrub someone with brushes, it can cause mild microdermal abrasions, which potentially could be a source for or a site where radioactive material can enter the body and now cause contamination, internal contamination. Likewise, if someone has any wounds, you may want to make sure that you thoroughly irrigate those wounds to minimize the chance that there is internal contamination of those wounds from radioactive materials. And as you're doing this, someone is going to be having a Geiger counter or a similar instrument that will be used to help measure the radioactivity of the individual. And you want to continue this process of washing, scrubbing, until the Geiger counter or radiation detection equipment shows that it is less than 2 to 3 times the natural background radiation, or until there's no further reduction in counts. Now, the medical management of this, there are several things that we need to do. We first need to focus on supporting the patient and recovering of the hematologic symptom and preventing infection. So obviously, we need to remove the patient from the source, ensure medical stability, and then proceed with decontamination. Now, this may require IV fluids and vasopressors because they may be hypotensive, because they may have fluid losses from that GI subsyndrome that we mentioned, or they may have other causes for their hypotension, such as shock from bad infections or injuries. Cytokines have been used in the treatment of patients that have developed acute radiation syndrome, and these would be things like filgrastim or Neulasta. Basically, these are growth colony stimulating factors that are used to help the body create more cell components of the blood system. So you're looking at things that will increase white blood cell counts, platelets, red blood cells, and whatnot. Probiotics have been recommended for medical management of acute radiation syndrome because this allows the gut to have more of that good bacteria to help prevent the space available for the bad bacteria to grow. So hopefully will prevent the translocation of bacteria into the bloodstream from the gut. These patients may require blood products because they're severely anemic, or they may need platelet transfusions because they're very thrombocytopenic. All blood products need to be leukoreduced and irradiated before administration. Again, you're going to be treating these patients as if they are a neutropenic cancer patient. You want to make sure that we're not giving them anything that can further worsen their medical condition. Serotonin receptor antagonists, such as ondansetron, should be given for nausea and vomiting. Some patients may require prophylactic antibiotics, particularly those that have had a severe decrease in their lymphocyte count. And the antibiotics that are going to be selected will be consistent with the Infectious Disease Society of America practice guidelines for neutropenic fever. Now, for those patients that have been internally contaminated, there are various treatments that can be used. However, they are specific to the radionuclide, and it's best to leave the decision of what needs to be given to a patient to the experts. So that brings us to this next point, which is how to treat people that are internally contaminated. And like I said, it's a very complex issue and it's isotope dependent. So someone that's been exposed to something such as cesium is going to be treated different than someone who's been exposed to, say, uranium. And there are various management techniques that can be used. You may give products that allow you to chelate the radioactive substance. Some are used to block the uptake. Some have isotonic dilution. Some alter the chemistry of the substance. Some displace isotope from the receptors. There's also, some people recommend excising tissue that may have been contaminated, so actually getting a surgeon in there to cut out the affected tissue. And then sometimes people would recommend bronchoalveolar lavage if someone has inhaled radioactive material. But it's a complex treatment decision, and there is a publication that was made by the National Council of Radiation Protection and Measurements. It's report number 161, and it deals with the management of persons contaminated with radionuclides, and that's over here on the right side of the screen. It's over 1,000 pages dedicated to this subject. So again, this just illustrates how complex it can be. So it's best to consult a specialist if you have somebody that has internal contamination or suspected internal contamination. So with the medical management of acute radiation syndrome, there are certain labs that you want to have. And again, this is just at a minimum. You want to make sure you get a CBC with a differential, and you want to do that every 6 to 8 hours. And again, you're doing this to monitor both the lymphocyte count as well as the red blood cell count, as well as the platelets. You want to get a complete metabolic panel to look at electrolyte status because they may be experiencing electrolyte abnormalities and fluid shifts. Again, it will also give you an idea if there are other things that are going on that need to be addressed medically. And then also you want to get a type and screen because many times these patients will require transfusions. Now, with these radiation patients, there's no real specific change to the initial resuscitation of the patient. So if someone comes in that's hypoxemic or hypoxic, you're going to be treating them pretty much the same way that you would treat any other patient that's hypoxic or hypoxemic. The only big thing is that you're going to be treating these patients as if they are neutropenic, febrile individuals. Now, it is important to get experts involved early. And these experts can be in the form of the radiation safety officer or the medical physicist of the hospital, medical toxicology or your local poison control center. Talk to hematology oncology since they manage patients that have had many of these effects from their cancer treatments. You may need to talk to infectious disease early, particularly for those patients that have a severely decreased white blood cell count. And there's also a group of individuals at a site that's called the Radiation Emergency Assistance Center Training Site, or REACS. This is a group that's located in Oak Ridge, Tennessee, and they are the international experts when it comes to radiation emergencies. They advise both the U.S. government as well as governments abroad, as well as many other private and public entities whenever someone has been exposed to radiation. Now, they actually have come up with an algorithm of how to triage and treat radiation patients. However, the algorithm doesn't really show up that well on a PowerPoint presentation. However, all of the concepts of it I've already covered in this presentation. So I would recommend that you do visit their website at that address that's located there, and you'll be able to pull this algorithm up and be able to visualize it and look at it in a much better format. Also including on this slide is their phone number, and I highly encourage you to write that down or save that into your phone in the event that you do have somebody that is a radiation victim or potential radiation victim, getting them a call as soon as possible. And then they will be able to assist you with everything from triage to treatment. So now that we discussed all of that, it's important to also look at several possible methods of exposure to radiation. You can have patients that have been exposed via a radiologic exposure device, otherwise known as a RED device, a radiologic dispersal device, or an RDD. You may have a nuclear power plant safety failure. You may have a detonation of an improvised nuclear device, or the detonation of a nuclear device. And this graphic here on the right is actually a small nuclear device that was actually created in the 1950s and 1960s that was able to be carried on a backpack and used by our U.S. Armed Forces in the event that there was an invasion of Eastern Europe from, at that time, the Soviet Union. Fortunately, these were never used. So radiologic exposure devices, this is when somebody just gets exposed to radiation via a source that's been placed either for nefarious purposes, like under the seat in a subway, or if they've been exposed via radiation from, say, a medical device that has had improper shielding or a break or damage to their shielding. With this, like I said, usually it's going to be causing more of just a radiation, not so much contamination. And the biggest fear from this, from a public safety standpoint, would be if a terrorist was able to put this, like I said, in a subway or somewhere else that can affect people. Now, it's been postulated that most people will not become very sick from this, given the short time interval that people will be around these devices, but the impact psychologically could be huge from this. Radiologic dispersal devices, or RDDs, this is what most people think of when it comes to like a dirty bomb. And this is a device that does not create a nuclear reaction. So it's not like a nuclear bomb. It's simply a regular bomb that has radioactive material in it. It can cause people to become contaminated. It can also create shrapnel that has the radioactive material on it, thus causing internal contamination in people who have been exposed to that shrapnel when it hits their body. Now, other forms of radiologic dispersal devices can be something just as simple as like the HVAC system in a big industrial location or a big commercial enterprise or a big university. It's been feared from public safety standpoints that somebody that has access to these HVAC systems could get a source of radiation and put it into the HVAC system and cause many people to be exposed to the chemicals or to the radiation. Now, nuclear power plant safety failures, this is something that we're all very familiar with because of Chernobyl and also what happened in Japan in 2011 at the Fukushima Daiichi nuclear power plant. And again, this is a picture of Chernobyl before the meltdown in the 1980s and a picture of the Fukushima Daiichi power plant. Now, the detonation of an improvised nuclear device is something that is very much feared among many people in the U.S. government. Fortunately, that has not happened. There was a movie that kind of described this called The Sum of All Fears. And this is when you have either a state or a non-state actor that is able to acquire the materials necessary to create a nuclear device. And they do that. And then they detonate that somewhere on our land or on the land of our allies. And then the detonation of a nuclear device, fortunately, this has only happened twice in Japan during World War II at Hiroshima and Nagasaki in 1945, but hopefully this will never happen again. However, there is a very high risk of nuclear war occurring. Currently, there is around 13,500 nuclear warheads, most of those belonging to the United States and Russia. However, there are many countries that do have nuclear weapons, and that includes the United States, the United Kingdom, France, Israel, Pakistan, India, Russia, China, North Korea, and there are several states currently trying to acquire them, such as Iran. And again, this just illustrates again the amount of nuclear warheads that are currently available, and again, most of those belonging to both Russia and the United States. So now we can talk about some radiation cases. So we're able to actually look at some real life examples of people who have been affected by radiation. Now, the first case we'll talk about is an incident that happened in 1987 in Guiana, Brazil. What happened with this, it involves a radioactive substance that was obtained and was inadvertently spread throughout a community. So what happened was two men found a capsule containing cesium-137 in an abandoned radiation teletherapy unit in Guiana, Brazil. They opened up the canister and found this glowing blue cesium chloride powder, and they thought it was pretty cool. So they took that home. They showed some of their friends and family, and they were handling this with their hands. One of them brought the powder to a junkyard owner to sell it to him for scrap. So the junkyard owner bought it, and again, he shared it with his family and friends and was showing all these people all this cool glowing blue powder. However, shortly thereafter, people started developing nausea, vomiting, fatigue, and having different type of skin burns and skin lesions. So one of the people that were exposed to this, cesium-137, went to the physician and showed him the powder that he had been handling in. And the physician notified the Department of the Environment of Guayas State about this and was concerned that there may be some type of radioactive substance causing these symptoms. So it took about 3 weeks, but eventually a physicist was sent to the area 3 weeks after the canister was breached. And the physicist was able to confirm that radioactive contamination had occurred. And the cesium-137 is a beta emitter and also does emit some gamma rays. Now, in the process of trying to work up this situation and trying to find out how many people were exposed, they created this schematic which shows in the upper left-hand corner, which is describing the facility where the radioactive material was first found, and then just kind of graphically showing, all right, where did the material move and who was exposed to it. And as you can see, it turned out to be a pretty complex distribution route because there were many people involved in many different localities. And they also made this, which is just a diagram of people that were exposed. And these people were the most severely exposed individuals that actually were handling the material. As you can see, it's a lot of people that were involved. And so what happened is that more than 112,000 people were monitored for possible contamination. And out of those 112,000, there were 249 people that were externally contaminated, but unfortunately 46 people were also internally contaminated. And this occurred mainly because they were handling this with their hands, and then they would, rub their nose or eat food, and that material would be transferred to their food or into their nasal passages, and they would be exposed that way. Now, they were all given Prussian blue for treatment. Those that were exposed had doses ranging from 1 gray to 7 gray. And remember that the LD50-60 that we mentioned before is 4 gray. So there are definitely people that had a potential lethal exposure. Unfortunately, 4 people did die from this incident. And here are some pictures of the incident. This is the actual abandoned radiotherapy clinic that had the source from the cesium-137. And here are pictures of people being monitored for contamination. You can see that they're using that radiation detection device or modified Geiger counter. And you can see here that you have people that are going in and having to look at all these different buildings and other places where the cesium-137 was kept at, because those places could be contaminated now. Same thing here in the junkyard where the cesium-137 was taken. Now, this is a picture of a skin burn, of a skin lesion from someone that was exposed to it. And this is on their thigh, and this was about 25 days after irradiation. And you can see that blackness in the middle of it, as well as the erythema and edema. Here's a picture of the hand of someone that was handling this material. And again, another picture of a hand that was handling the material. Now, that brings us to another case. This one is very famous and well known, dealing with Mr. Alexander Litvinenko. Now, Mr. Alexander Litvinenko was also known by the alias of Edwin Carter. He was a former Russian security service agent who was granted asylum to the United Kingdom in 2000. And part of the things that he did in the United Kingdom was acting as a consultant for the British intelligence services. And he was very critical of Russian President Vladimir Putin and the Russian government. And so he would tell them different things that he had known and found out about the Russian government and intelligence agency. However, on November 1st, 2006, he did meet up with 2 former Russian intelligence workers as well. And then later that night started developing some abdominal pain, some nausea, some vomiting, some diarrhea that he initially thought was just secondary to like some gastroenteritis, didn't think much of it. However, symptoms persisted and worsened, and on November 3rd, he was admitted to the Barnet General Hospital for gastroenteritis and dehydration. However, things did not improve for him. Things got a little bit worse, and on November 7th, they identified Clostridium difficile, or C. diff, that was in his stool. And when this occurred, and with him knowing he's not getting any better, it's getting worse, he decided to reveal his true identity to the hospital staff, including the physicians. Told them that his name was actually Alexander Litvinenko, and he was a former Russian intelligence officer, and he actually was scared that he had been poisoned. Now, as you can see in this picture here, this is eventually what he looked like, and compare that to how he was previously. He had a full set of hair and obviously was looking more vibrant previously. Now, this is the timeline of the events that happened during his hospital stay. And it's important to really go through this to understand the way that the radiation illness actually can affect the body. So on hospital day 11, he developed a fever and started having worsening neutropenia. And he was started on antibiotics and given Neulasta, which is one of those colony growth stimulating factors that we mentioned earlier. And that was given to help improve his neutrophil count. However, on day 13, he developed alopecia and mucositis, and he started having worsening cytopenia. The hospital staff noted that he began to look like someone exposed to a toxin or chemotherapy or radiation. And he and his wife told hospital staff that they feared that he was poisoned because they said that his symptoms were similar to those symptoms that they had learned about during his training in the Federal Security Service of Russia and some of the poisons that they used or allegedly were using against some of the people that they did not agree with. So clinical toxicology was consulted and a sample was sent for a heavy metal screen. A Geiger counter was used to screen the patient and only background radiation levels were detected. And that's important to note, and that's something we'll discuss about in a second. On day 15, bone marrow sample was taken and it was acellular, so the bone marrow was not working. On day 16, the heavy metal screen showed a slight increase in his urine thallium concentration, but below the toxic concentration. On day 17, he was transferred to the hematology unit at the University College of London for specialist support and treatment of bone marrow failure. The specialist doubted that he had thallium poisoning since he did not have peripheral neuropathy, which is a key finding in thallium poisoning. But because there was not a clear explanation for his alopecia and GI symptoms, he was started on oral Prussian blue as a treatment for internal contamination with thallium. On day 18, he became jaundiced and began having hematemesis. On day 19, his EKG showed inverted T waves, but his troponin was normal. He was transferred to the intensive care unit. He remained febrile and had elevated inflammatory markers. And his therapeutic regimen was broadened to include coverage for antifungals. On day 20 and 21, he developed acute renal failure, and he was noted to have increased conjugated bilirubin levels. And on day 22, they obtained a blood smear, and they noticed that the blood smear, when exposed on a glass slide to radiograph film, the film exposed to parts of the blood smear not covered by the glass cover slip developed opacity, which is consistent with the presence of a radioactive substance in the blood. That glass cover slip was able to block some of the radiation, hence why the part of the smear that was covered by the glass cover slip did not show the opacities on the radiographic film. His urine underwent gamma radiation spectrometry and showed an 803 kilovolt photon emission, which is consistent with polonium-210 poisoning. So a sample of his urine was sent for confirmatory testing. Unfortunately, he rapidly deteriorated and suffered a cardiac arrest, but was resuscitated on hospital day 22. On hospital day 23, though, he had another cardiac arrest and unfortunately died. After his death, the urine confirmation test came back, and it did show that he was exposed to polonium-210. It did confirm that. And on this slide here, we see the blood smear on the left-hand side, which shows the opacification of the exposed area of the smear. And again, that area was not covered by the glass cover slip. The area of the blood that was covered by the glass cover slip was able to block or shield the radiation, so therefore preventing it from being transferred to the radiographic film. And the table on the right-hand side, you can see actually shows his blood levels for the different blood cell counts, as well as his liver and renal values. So the outcome of this obviously was thoroughly investigated by the police, and they found that the tea that he had ingested from that meeting with those former Russian intelligence officers had been laced with polonium-210. And it was suspected that he was poisoned by these officers due to his criticism of President Vladimir Putin. So a little about polonium-210. It decays to lead-206 by emitting one alpha particle with occasional gamma ray emission. Its half-life is 138 days. And since this was an alpha emitter, and remember alpha particles, they can do a lot of damage to biologic tissue, but they can't travel far, and it's very easy to shield oneself from these particles. That's why that glass cover slip was all that was needed to shield the radiographic film from the alpha particles, and also why the people that were sent to kill Mr. Litvinenko were not exposed, because it can be very easily transferred. All it takes is being placed in a container that has a thick enough wall around it to prevent those carrying the alpha particles from being exposed to it. This also explains why the initial Geiger counter read when he entered the hospital did not really show any elevated levels of radioactivity, because his own body tissues were blocking the alpha particles from going to the Geiger counter to be counted. And again, the early symptoms of polonium-210 just mimic an infectious process, just looks like a viral illness. And it can be possibly chelated with sodium-2,3 dimercaptopropane 1-sulfonate, or unithiol is what can be used to chelate it, potentially, depending on how severe the poisoning is. And so even though he was receiving some medication for the internal contamination, it wasn't the right one. Again, that illustrates how complex some internal contaminations are in terms of treatment. Now, the last incident that we can talk about, it happened in 1999 in Yanango, Peru. And during this episode, a worker was working with a radiographer at a hydroelectric plant in Peru. And that welder picked up a lost Iridium-192 industrial radiograph source on February 20th, 1992. He picked it up and put it in his pocket for several hours. He didn't apparently know it was radioactive. And about 6 hours, though, after putting it into his pocket, the worker began experiencing pain in the back of his right thigh, right where that back pocket was. He went home with the source and started to have some more pain in the area, and actually exposed other people in his family and his home, because they picked up the source of that radiation as well and started handling it. However, the radiographer discovered that radioactive source was missing. He'd noticed that around midnight, and so he came to the welder's home at 1 a.m. on the 21st of February and discovered the source. So it was detected and discovered, not too long after it had been taken. And the welder went to a physician, and it was estimated that the whole body dose was about 150 rem, although the localized doses were much higher, up to 10,000 rad in his buttock, where the exposure occurred. He experienced severe dermal injury, suffered the Hematopoietic Syndrome of Acute Radiation Syndrome, and eventually underwent amputation of his right lower extremity, followed by a hemipelvectomy. And here's a picture of that pigtail source, where one of the tips actually is the radioactive source. And this is what the initial cutaneous injury looked like. This was on the 22nd of February. So again, this was only 1 or 2 days after the source was near his leg. And then on March 1st, you can see that it has gotten worse. On May 3rd, this is showing a severe progression of the cutaneous injury. And then on 18 October, this picture shows how he eventually had to lose his entire right lower extremity and part of his pelvis as well. However, he started having complications, including his perineum becoming involved with also some infection. And again, this picture here that was taken on December 14th shows that spreading necrotic lesion to his entire perineum. And this table shows how his white blood cell count and platelets did begin to drop after being exposed to this source. On hospital day 1, or day 1 after exposure, I should say, his counts were pretty much normal. But then on the 14 days after exposure, you can see that his white cell count dropped to about 1,500, which was originally 7,600. His lymphocyte count dropped down to 30. You can see his platelets dropped down to the 99,000 or so. So not a significant drop, but did have some drop in his platelets as well. So the key points with ionizing radiation is that it directly or indirectly damages DNA or other biological structures. There are different types of ionizing radiation in the form of alpha particles, beta particles, neutrons, X-rays, and gamma rays. It's important to remember to use the ALARA principles for protection, which is decreasing the time of exposure, increasing the distance between you and the radioactive source, and then using some type of shielding to protect yourself from the radioactive exposure. Remember that the earlier that you vomit, the higher the likelihood for a significant exposure. Remember to trend the lymphocyte count to estimate the radiation dose. The faster and the more significant drop in lymphocyte count is consistent with a higher radiation dose. Remember to discuss any type of radiation emergencies with a radiation safety officer, medical toxicologist, or the REACS personnel in Oak Ridge, Tennessee. And remember that internal contamination requires specific treatment that must be discussed with those subject matter experts. So thank you for listening to this presentation. I hope you were able to learn something from it. And if you have any questions about this, please continue to watch the YouTube series here with the Blue Ridge Poison Center.